With that, I'd like to introduce our keynote speaker. And I'm gonna read a little bit of the background, so forgive me, I don't have it memorized. But Colonel Duncan Milne, retired U.S. Marine Corps Colonel. He is the president of the Dixon Center for Military and Veteran Services. Colonel Milne is an experienced leader with 25 years of active duty combat and non-combat experience in the United States Marine Corps. While on active duty, he primarily served as an AH-1W attack helicopter pilot. Colonel Milne has served at the highest levels of our military and government, including in the Office of the Joint Chiefs of Staff. I'll put a link up so you can read more about him along with the team at Dixon Center and the Dixon Center in general. But with that, I would like to hand it over to Colonel Milne if he's ready. And Randall, do we have Colonel Milne live? There we go. Outstanding. First transition is successful. Thank you for joining us, sir.
Hey, thank you, Dr. Manning. It's a pleasure to be here, and I look forward to this entire day. I looked at the panels, and just the depth and breadth of knowledge that's going to be presented, I think, is wonderful. I have to stand up and apologize to the audience for, not apologize, that's the wrong word. Unfortunately, you get me today. Due to unforeseen circumstances, our chairman, Colonel David Sutherland, is not able to attend this discussion. I guarantee you the next one he'll be out front and center, because this is the work that feeds our soul. Dixon Center started when Dave and I were on the Joint Chiefs of Staff, and Dave was working directly for Admiral Mike Mullen, the chairman. And Admiral Mullen came back and said, I'm out traveling a lot, and we get the question that people want to help veterans and those touched by military service, but they don't know how. So Dave was charged with kind of answering that question and going out into the communities and trying to connect resources and needs for our veteran population at a time when people were leaving the service due to discharge post-surge in Iraq and Afghanistan, and the needs were very high. So that was how the Dixon Center was born in 2012, a center of excellence that enables organizations and individuals across the country to maximize their impact on veterans and those touched by military service in the communities where they live. So one of the things we found out early on is that a lot of the people in the countryside, when you ask them about veterans and those touched by military service, their needs and challenges, their reflexive answer was, well, the VA and the government take care of that. And the reality is that that's not true. The VA and the government are big parts of that equation, but those big government services aren't readily available outside of certain areas in the most part of the country. We have 18 million, 19 million living veterans in the United States, and a lot of challenges out there for some of them who aren't plugged directly into health systems. As I was preparing for this discussion and on short notice, kind of knowing that what we wanted to talk about, I was thinking the other night of the challenges that we all face with the pandemic and some of the incidents going on around the country. And my thoughts this morning are on people out in California with fires, and and the folks down dealing with the hurricane on the Louisiana coast. I had command in Louisiana, Belle Chase, and left it 3 weeks before Katrina hit. So I understand the impacts that that'll have on lots of people. But one of the things I was really struggling with was we have challenges that have morphed over time. Sam Whitehurst will be on the next panel, myself and Dave Sutherland. We talk a lot about the needs of our veterans and their families evolving, not going away. And I took that a little bit further. I was outside in a local venue here in Maine. I'm up in Maine. We're a very dispersed state. We're able to gather in groups outside. And the innovators had set up basically a outdoor movie theater for people to get together in a center of gravity in a community. And the first movie they played was Back to the Future. And I kind of reflected on Marty McFly and the sequence in that movie on how he went back in time and was very, very, very concerned, or the doctor was, about impacting things in the past that would change outcomes in the future. And I kind of thought about our veterans in that, and that we're kind of in a back to the future moment. And the premise I would give you for my comments today is that as Sam and Dave and I would say, the needs of our veterans are evolving, they're not going away. I would almost propose to you that the needs of our veterans are devolving. We're going to face some of the challenges that we thought we had made progress on reemerge. And we'll talk about some of those things here in the next couple minutes. All of the issues that we deal with in terms of wellness and health, I hope some of you are familiar with the 8 dimensions of wellness. And at Dixon Center, we kind of use that as a lens to look at intersections, where there are gaps, and how some of these things that we don't necessarily think are attached to wellness really impact our sense of well-being. Now, one of the challenges with the veteran environment, and we work with all demographics, one of the challenges is veterans generally don't want help. And as a matter of fact, I kind of bristle at the word help, but sometimes we need assistance. The vast majority of veterans, when they come out into your communities after leaving active duty service, thrive. They do outstanding. They reintegrate, they work well, they plug into the local health systems, local education, and they become foundations in their communities quite rapidly. But some don't, some struggle. And some struggle because it's an access issue. We've done pretty well on a lot of things over the last 8 to 10 years. My concern is that we're going to go back and have to address some of these things again. But some of the things that we've done real well, you know, the VA's done a great job, but there's still room to improve on what we do with caregivers, not just in their education and their support, but their respite. And, you know, during times like this, when people are isolated, that becomes even more of a critical issue. We're moving the needle in the discussion on opioid abuse and prescriptions for treatment. That still has a long way to go, and we need to include, you know, big pharma, HMOs, doctors, and other parts of that system to address the scourge. And again, I live up in Maine, and that genie had got out of the bottle a while ago, and trying to put it back in, and its impact on families is very, very challenging. It's not near being over, unfortunately. I'm heartened by some of the other aspects we've moved the needle in terms of the effects of war trauma on our veterans. Military sexual trauma is being discussed out in the open now. The effect of burn pits and other issues and toxic exposure is being discussed and aggressively pursued, so we can get offsets and recognition of the challenges that's created for the health and wellness of our veterans and the impacts on our families. Well, the reality is, you know, when you've met a veteran, you've met a veteran. Each and every one of us is very unique, and each and every one of us lives in communities that are very unique. Our communities across the country all have different requirements, capacities, and resources that they can, based on what their desires, use to increase impact in a positive way for veterans and those touched by military service. But again, communities aren't the same. Cookie cutter solutions of big government don't work. Portland, Maine, thank goodness, is nothing like Portland, Oregon. So all those things have to be addressed at a local level, and that's really where we see this being impacted in terms of health and wellness. The pandemic has created new challenges, as you all know. While the physical challenges are limited, they can be dire, and traumatic impacts on families across the nation. But some of the secondary and tertiary effects of isolation, of quarantining, of lack of supportive services that people have come to rely on, can be problematic. A lot of our veterans, far too many of them, and have underlying conditions that make them susceptible to the virus and making it more severe than it may be. One of the biggest challenges in our space in dealing with veterans and integrating them into healthcare systems and employment and everything else is transportation. I live in a very rural area in Maine, and the tyranny of distance and conditions of roads and simple things like that really impact our ability to get quality and timely care. COVID-19 has created great backlogs in healthcare services. Things have been put off. treatments that are required. If they're not, early on, especially if they weren't life-threatening, they were put off. How do you meter those back on in a responsible and reliable way so people don't prolong illnesses or prolong conditions that are impacting quality of life? One of my biggest concerns that we have is our national scourge of veteran suicide. The effects of war trauma on a lot of people have led to crushing isolation, and that exists, COVID-19 or not COVID-19. And we fight that every day. I know a lot of veterans I've spoken with out and across the state of Maine, but out and across the country, who are even more isolated now. And I'm concerned about the impact that's going to have on the number of veterans committing suicide across the nation. I've heard estimates of national suicide rates 10 to 13% increase. I've read a lot of anecdotal stories about how this is going to impact these members and their family members as we go forward. On the flip side of that, telehealth, as you'll all be talking about today, has rightfully and necessarily expanded. So we have in our country some veterans who are isolated and want to be or stay that way, unfortunately. But some, ironically, this has kind of pulled them into the technology realm and forced them to interact with people in a different way. So there's a positive aspect to that. But at the end of the day, the personal interaction that we share when we meet and discuss and support and share in affinity groups and all those interactions is a lifesaver for a lot of these people, and they're missing it right now. I think the integration and the increased fidelity of telehealth obviously is going to have an impact on just people's physical health, but it may have a good impact on drawing some of those people out that have closed themselves off to society. The veteran suicide issue is not going away. The demographics are skewing a little younger now, which is concerning. But as healthcare providers, I think one of my biggest bit of advice that's out there is a story that I share quite often with people all across the world. I met a young man in Texas about 2 years ago, and it was at a large gathering. And we get really used to that term, "thank you for your service." And sometimes it kind of becomes a platitude, kind of like, "Hey, it's a nice sunny day outside." And what I've always asked people is, go a little deeper, peel the layer of the onion off just a little bit more, and have that secondary conversation. Ask them what they did, ask them where they've been. Just that interaction may that one day be the interaction, reconnection to society that veteran or family member needs to pull them back from that abyss and that staggering isolation and desperation that makes them consider taking their lives. And I would say in the healthcare arena, that is an avenue that needs to be approached all the time. You'll never know. And this young man in Texas said, because we asked him that question and we have that dialogue, that he was in a circumstance where that very question saved him from going to a very dark place. So I ask you to consider those kind of impacts when you have personal face-to-face interaction. The big government does big government things well, but they don't do this. They don't have conversations. And we lack that society, especially at a time when America's forgetting their wars. We can't let them forget their warriors. And the American society is very detached from military service now. So that communication, that constant discussion can be life-changing. I think one of the things when you look at the 8 dimensions of wellness, one of my big concerns as we go forward, right now, the Department of Defense is allowing a certain number of transitioning service members to be retained on active duty, and a number that's pretty large. Normal attrition for the Department of Defense every year is about 200,000, and that varies a little bit depending on world events. So every year, 200,000 people, just by nature of their enlistments or their terms of service, depart the military. Right now, we have a significant addition to that will be departing the military, sometime in the next few months. So add 200,000 plus whatever that number is. My concern is that in this this economic state that we're in right now, before we were at COVID, we had COVID-19 ramp up. Veteran unemployment was below the national average. Competition for hiring veterans. Underemployment was another issue. We had folks taking multiple jobs, which adversely affect quality of life and all the other wellness issues, or all the other dimensions of wellness that families fight to maintain balance. So we were creating a lot of jobs, and there were a lot of big press releases and moments for jobs, but we weren't creating careers where people were retained and had benefits and were able to work and pay attention to those other things, their health, their spiritual wellness, financial, all that stuff. I am concerned that come next summer, we have that same bow wave that we had back in the late 2000s, 7, 8, 9, 10, where we had high unemployment rates, but also we have a very challenging job market. I'm concerned that we're not going to be focused again on building careers, we're going to be focused on jobs. So we need to keep that in line, in mind, as that bow wave that I think is going to be there really starts to raise its ugly head, because that's going to affect all sorts of issues, all sorts of health issues. Finances and jobs are a fundamental key aspect of people's well-being, and when they don't have that, then a lot of the other things just simply don't happen. There's not transportation, there's not healthy diets, there's mental health issues that may be put aside in terms of treatment. I kind of want to finish up with almost a kind of call to action for all of you. I talked about the devolving needs. We're going to go back. We're going back in time. We have an opportunity to do these things over again and do them better. When we had the employment crisis for veterans, again, it was focused on just getting jobs. We need to move back to let's get careers for these folks. We kind of get a devolved do-over, for lack of a better term. There are a lot of things that we have learned, and there are a lot of things that we've set aside during this pandemic. I think what every organization here that's talking today needs to have a COO, and not your traditional COO. You need to have a chief opportunity officer. You need to have somebody that's sitting in the corner that's paying attention to the things that you really don't need to do anymore, and paying attention to the opportunities to pivot or change your model. And a lot of organizations are doing that, but too many aren't. And we need to do that in the veterans and military family space as well. This telehealth is a good example, but we do have to find new ways to reach out to those veterans who are isolated and to their family members that are suffering. I really think we have a great opportunity today during this discussion to address many of those issues. And I really hope that if you have any questions at all for myself or for Colonel Whitehurst or Colonel David Sutherland, reach out to us at dixoncenter.org. I'm sure emails will be provided. We'd love to talk to all of you, because like I said, this work may not put food on our table, but it feeds our soul, and it's very important to us. And again, these requirements, these needs are not going away. And I wish you all the best. I'll be here to answer any questions you want, or Sean, if you want to just take it away and lead a little bit of a discussion, I'm fine with that. But thank you all for joining today, and we'll get you Dave Sutherland up here in front of everybody as soon as we can.
Excellent, thank you, sir. I think that was a wonderful overview of why we are doing this today, and much better said from your perspective. I think that we fielded a few questions, but I want to encourage people, if you've got more, please put those in the question box, and we'll be tracking those and and the questions that we're able to answer, we're going to tackle. We've gotten one from someone who's a civilian provider in the VA system, and asked, sometimes I'm afraid to dig deeper because of the potential of PTSD. Any specific examples of how to ask that as a civilian? I wonder if you could talk to that question a little bit, because that's probably not just one in our audience that are thinking about that.
Yeah, and that is a sensitive area, and I hate using the term PTSD because we're stigmatizing people right away. The effects of war trauma take many different shapes, and war trauma that forces isolation and post-traumatic stress, it can be very difficult. But you have to understand, many folks don't want to come out and say that, because that term carries with it a lot of baggage, and it carries with it some of the baggage of overprescribing medications, some of the baggage of even access to lifestyle choices in terms of hunting and things like that. You know, there's initiatives across the country that restrict access to a lot of opportunity for people that have been diagnosed with what, you know, clinicians want to tag as PTSD. But again, it's that discussion of getting past that first entry-level discussion of who you are and what you're feeling, and asking people what they've done. Big medical systems don't necessarily want to portray personalities. You know, they're more about strict guidelines, and I'm talking in generalizations a little bit. But I would encourage anyone who interfaces with a veteran that has, you know, traditional symptoms or challenges or characteristics that they're displaying or talking about, to have that next level discussion, like I said before, and don't be afraid to do it. The veteran will tell you, or he won't. But try to keep away from that stigma of a disorder.
Excellent, very helpful. And yeah, the PTS versus PTSD is sometimes a way to just kind of slightly destigmatize it, but I think there's a much broader effort to do that, and that destigmatization brings people into the clinic. If people aren't afraid to ask about a problem, then they come in. And for folks I haven't had the chance to introduce you to my background, I was a federal civilian under Department of Defense, as well as a contractor for 18 years. So I was in supporting the military health system, so I got to be familiar with it a little bit. I'm not a clinician, nor am I a veteran, but I got to spend a lot of time around both of those from the context of research and translating findings into practice. And one thing that a now retired neuropsychologist at the Tampa VA used to say really resonated with me, which was that you just got to get them in the door. And if there was instead of having a mental health clinic, if you just had a sleep clinic next door, everyone would be going in, because they could go in and ask about sleep without any stigma. I can't sleep, and then that could start the conversation. And that was. Oh, go ahead, sir.
No, I don't mean to interrupt you, but you made me think of something I really want to stress is. Again, we have 18.8 living veterans in the United States, 18.8 million, excuse me. 1.5 million of them are at or below the poverty level. And we also have a very old demographic of veterans. When we think of PTSD, and we'll use that term, we think of the media version, which is the 18 to 34-year-old demographic. And when in fact, the people that are most at risk for suicide and also have post-traumatic stress are some of our oldest veterans, the 55 and older veteran. And the challenge with them is when they came home from their war, when they came home with their trauma, they walked into a society and a system that told them not to seek treatment, not to reach out. And because it was a big monolith and it was a bureaucracy, and they were told, don't say you were in the military. I mean, and I can put it in my context, as you said, I flew attack helicopters for 25 years. I was spring-loaded never to go see a doctor, never. Because if I saw a doctor, something bad was going to happen, and they were going to tell me I couldn't fly. But, and take it to that extreme, we're kind of hair-triggered to not want to seek out services that may be beneficial to us. And that's extremely true in the older generation of veterans. So when you're seeing folks, don't always mirror image the veteran that you see in Iraq and Afghanistan footage. It may well be those more vulnerable older folks who actually have the underlying conditions and actually have a greater need for service than the young folks.
Yeah, I've seen that myself and some of the people I've gotten to interact with in my family. It's amazing. You get folks who, you know, I'm a scientist, I'm not a clinician, and they'll come to me at you know, Christmas and say, hey, who do I talk to? I'm like, go to the VA, talk to a provider, and they don't want to. And it seems like it helped me realize what a barrier there was. Actually, we've got a couple of our next panelists who are starting to come on, so we might be able to just you know, continue this discussion with you, sir, but bring our next panelists on before they get into the full aspect of their discussion. Kind of spread it out a little bit, because we've gotten a couple other good questions. One that I gave an initial answer to, but I think is worth having a dialogue. You said something about careers, not jobs. And I think that's important, because, you know, giving someone a job helps them, you know, get money and earn their way, but it doesn't really give them the long-term planning that a career may be. I would also say that the question we got, and I'm trying to find it here, forgive me, about hearing from Consensus, you know, and we're Consensus House, so we're a newer spinoff than Consensus, but hearing what those of us on the private side can do for veterans. You know, I responded, we have some advisors who are veterans, and our chief medical officer is, and they'll be speaking to it. And obviously, we started day one engaged with Dixon Center, so we have an interest in this. But from a tangible perspective, as we as an organization get better, or if there's larger organizations out there who have the resources, what can they be doing in tangible terms to help veterans from an employment standpoint?
I think the most important thing, and I've said this since day one working in the space when I retired, is hire veterans to interact with veterans. There's an aspect of translation that needs to happen. Leverage your strengths of your organization, whatever it is, whatever you do, with the help of a translator, so to speak. Because that passion that's built into that person that's working for you can spread throughout the company as you go forward. One of the challenges is a lot of folks, like you said, don't know how to approach the groups, find and fix and focus on veterans and their families. Organizations like Dixon Center can help do that. But again, if you build that in-house, you know, I was at one conference and I said, you know, if you hire a veteran, hire two and add water, and they'll take over the company. And they'll be respectful of the challenges of veterans. We see it all the time. We see it in corporate America across the country, where they set up affinity groups. And some of these may be based on specific needs in the community or specific conditions that some of them may have. There may be a veteran affinity group for transportation, you know, people that need to support each other. One of the biggest challenges, again, for everything that we do in the veteran space is transportation, getting to services and getting to employment, and it becomes a big challenge. And companies can help with that if they want to. And there's innovative ways to do those kind of things. I don't know if that answers your question, but
Definitely a start. Definitely a start. And there was a. Oh, I'm sorry, Sam, please.
No, I'm sorry. I just, Sean, I just wanted to jump in real quick. This is really in reference to the very first question that came from the civilian provider about, you know, approaching or working with veterans, reference PTSD. And I just wanted to share this with the audience. Everyone, you'll get to hear from me here in about 20 minutes or so. We're going to kick off our next panel, Sam Whitehurst. But I just wanted to share, again, I just wanted to share this story. Hopefully it'll provide some context in dealing with that issue with PTSD. So I work with an organization that has produced a documentary about military caregivers. Incredibly powerful documentary. It's called The Weight of Honor. And so I've been working with them for quite a while now, and we do screenings, and I've sat on some panels to discuss the film after it's been screened in front of different groups. So every time that one of those events is coming up, I always make sure I've watched it. I've watched it about 5 or 6 times now. And what I have found is that every time I watch it, it's very emotional. You know, hearing these stories about caregivers really brings back or triggers some memories that always come flooding back when I watch it. And I was talking with the producer of the documentary the other day, and she was kind of apologizing for that, the fact that you know, how emotional it is for me to watch it, how it does trigger some past memories and bring some things back. Probably some of the things that we would characterize under what people normally call PTSD. And I told her, I said, there's really nothing to apologize for. I mean, it is emotional for me to watch it. Yeah, and like I said, every time I watch it, I have those moments where I just have to kind of step back from the computer a little bit. But it's not necessarily a negative process that I'm going through. I have found it very therapeutic. So I think we sometimes associate, you know, the term PTSD and the process of dealing with it as sometimes being negative. And I would say it can be very therapeutic as well. And like I said, I always come out after watching it, I always come out the other end, I think, in a better place than I was when I started. So even though it is emotional and it maybe triggers those things we associate with PTSD, it's not necessarily a negative process that I'm going through. And I think Colonel Milne said it right. You know, it's just approach it from the idea of dropping the D. Don't, you know, the disorder is what makes it a pejorative term. I think everything that precedes that D, that disorder, is actually can be part of a normal healing process. So I would encourage, just like Colonel Milne said, I would encourage you to engage in those conversations. Don't hesitate from engaging with them, because I think more often than not, it is a very healthy process. So yep. I thought it was I just wanted to make sure I shared that with everyone. And so I'll jump off now and I'll wait for our panel to start here shortly.
That's great point, Sam, and nice jacket, by the way. But I'll tell you what, and the last part of what Sam said is really, I think, the crux of everything that we kind of talked about today. It's the connection. It's the connection to the veteran. It's the connection to the veterans' families that makes all the difference. So don't shy away from conversations. It's easy for us all to turn inward, especially in times like right now, where we're kind of forced or encouraged to turn inward. But we have to struggle and break through that barrier to have adult conversations about challenging things. And post-traumatic stress is a challenging thing for too many people in this country. So, you know, conversation goes a long way to healing.
Very true, very true. And I think jumping back to the employment question and discussion, there's been several great comments that have been in the question area as well. So I'll you know, we'll be plucking those out and sharing them, as well as Rosie just put some good information in the chat box. And I also shared the link to the documentary that Sam was talking about. But one particular comment I think would be very helpful to carry back. You may already be familiar with this group and these efforts, but there have been, Joyce Hunter says, there have been several initiatives around service people in agriculture. Take a look at Fields for Valor, who run a farm that feeds about 30 veteran families. And he also supplies food for 3 shelters that house veterans in Montgomery County. And I know Joyce has mentioned before in other forums that there's a lot of work going on in the agriculture industry for intersecting with veterans and agriculture, both for career and employment, but also for well-being.
Yeah, absolutely. And we are working with organizations like that and with USDA and a bunch of other folks. Because one thing you got to keep in mind is when service members transition out of the military, there's this automatic assumption that they want to do what they did in the military. You know, they're going to stay around the base. They're going to, you know, but veterans seek out opportunity and quality of life. Those are the 2 things they're looking for post service. And truck driver in the military may not want to be a truck driver in life. He may want to go be a farmer. There's an organization just north of where I am here in Maine that does the same thing, or is trying to promote the same thing. So what we don't want to do is pigeonhole our transitioning service members into the careers that they had before they left service, or the location they were in before they left service. It's not always true. And again, it speaks to, if you're talking to a veteran, you're talking to a veteran, that one person, and we're all different. So great point.
Yeah, definitely finding ways to, and we'll talk about this a little bit later, some of the ways that in session 4, the ways that we can better connect people with what's out there. Sometimes there's the perfect solution is out there, but the person doesn't know about it. So how do you bridge that gap?
Yeah, and I think I'm looking forward to your discussion on emergent technologies out there now, so we can do away with some of these legacy things that we've had to keep doing in the veterans healthcare world for a long time. And I think we're all starting to broaden our horizons a little bit about what is acceptable and what's not. Whether it be privacy information, whether it be sharing of information that we've had challenges with in the veteran health area, making that stuff more effective, and as the technologies emerge, making them of a higher degree of fidelity than they exist right now. So yeah, and making sure the tech works for the people too. Tech is sometimes its own thing and runs aground and gets people off track with what people need. But if you look at what people need and you build that into the tech, it makes it a lot more useful. And I think thinking about tech as a tool, it's a tool that sometimes can do new things, but a lot of times can just do the things we already do better and faster if applied the right way, if applied with human-centric design for that community that you wanted to work with. And so I think that's something to keep in mind. Tech without people isn't very, very helpful. Right, and I keep going back to transportation, but that's what I see as our technology. Our new technologies that's the transportation mode. It doesn't have to have wheels on it. So when you talk about the dispersion of veterans across the country and into rural areas, we talk about shortfalls in infrastructure. We talk about access to broadband services in some parts of the country where it's not readily available, which forces, unfortunately, pigeonholes people back into that isolation when everybody else is doing all this wonderful stuff on their computers and working from home. And sometimes that becomes even more difficult or reinforces a negative if we don't have that infrastructure. I mean, just like we build bridges, we don't build bridges so you can go see your grandmother. We build bridges so you can move commerce over them and to drive the economy. That's why they're there. It's just nice you get to go see grandma.
Yeah, it's the little things that don't always have the funding for them that we need to figure out how those smaller efforts, those microservices, I think heard them called, can sometimes take place. There's a number of people who've put great comments in the questions, so I think we'll try and collect those. Unfortunately, we can't grab everything that's in the chat, but you can communicate to each other on there. But are there any other questions for Colonel Milne? I've got a few that we can walk through, but I want to make sure the audience has a chance to chime in if they've got anything. Put them in the question box if you do. One simple solution, going back to the earlier question about what's a civilian in a VA setting able to comfortably do to start diving deeper and dig deeper. A quick and easy solution offered up in the question area was just you can always start with asking what the person's MOS was. So just get talking about what they did.
Absolutely. And when you do that, and that's the comment I had with my buddy down in Texas, when you do that, the veteran won't probably talk about themselves, but they'll probably talk about the people they served with and all the neat things they've done and where they've gone. And again, you're peeling away that layer of the onion just a little bit, just engaging just a little bit more. And it's not just hey, thanks for your service. It's, hey, taking interest, just like we all want to have interest taken in us about our lives and things, our experience that we've had. And if you can get to that second or third level of conversation, people will start communicating their problems to you where they may not have before.
And that dialogue is important, and that takes me to a question that I'd just like to get your thoughts on. one of the things, and again, I was never in the service. I was around as a contractor and a federal civilian for a long time, from 99 through 2017. So it was a very slow learning curve for me of what the culture was, how military culture made things different for individuals. And I, as a scientist at first, and then a research administrator, looking at it more broadly, was sometimes focused on the wrong things, looking for that shiny object that would fix everything, or that pill that would fix everything. And then as you look at it, it seemed a lot of times it was the dialogue, it was the information sharing, it was the shared experience, getting people who had been through, in the case of trauma, been through a traumatic experience, to talk with others who had that same experience. We obviously just hit a time in our country and in the world where that person-to-person communication has become harder. What either already existing or do you envision in the future can help bridge that gap? How do you can't have the same meetups for people who served in the same capacity? How in the virtual world can we bridge that gap a little bit better, and what can be done to help facilitate that?
I think we're kind of doing that. The good side of that question, that shouldn't be a good side, but it is, I kind of talked about a little bit earlier, is that a lot of our veterans today are pretty tech savvy. They know their way around a computer. And a lot of our older veterans who didn't want to be tech savvy have learned to get around a computer, which has encouraged and enabled them in ways that they might not have been before. But I think what we really need to focus is on communities. Again, every community is different, and everyone's operating very differently in this environment. I live in rural Maine, and there's, I think, 4 people in the hospital in the state that have COVID. Obviously, very small, spread out area, and that allows us to do a little bit more interaction, both physically and over systems like this. That's not the same across the country, obviously. But I think what we can do to affect that change, one is systems improvements, but 2 is building community connections in whatever means you can, whatever that transportation means is. Affinity groups and communities reaching out, whether it's a veteran service organization or an organization at the hospital of people with similar challenges, any kind of those that bring people together. And consistency, I think, is the most important thing, because the people that suffer in this system are the ones who fall in the cracks, are the ones that fall out of routine. We like to call it battle rhythm. We like to call it whatever you want. But if there's an expectation of attendance, performance, and interaction on a positive level, people will keep coming. It's when we get kind of a little sloppy in our discipline of interacting with people, that people will just check off the net literally and go to their place where they're keeping secrets, and that's not a healthy place for anybody. So I really think it is organizations, like-minded organizations, coming together and having a disciplined dialogue over time as systems develop. That's kind of a mamby-pamby answer, but everything that I kind of focus on is that center of gravity in your community, whatever it is.
Excellent. And I think we have time for one more. And forgive me, I'm getting used to this feed, so I'm reading a lot of great dialogue, but I also don't want to miss any questions. And we got a couple others in here that I'd like to see if we can touch upon in the last couple of minutes. One is, do you have any recommendations for tech organizations like Consensus Proper on how to, and that's our parent company, on how to appropriately communicate with, address, or handle veterans' needs? And I have a couple thoughts on that, but you first, sir.
Can you say the last part of that again?
How to how to appropriately communicate with, address, or handle veterans' needs. And you had said, hire veterans is obviously one straightforward answer, but I think, in addition to that, how to even engage that community so that you might have people who are looking to be hired, or know where to find the people who are available to be hired.
Yeah, there's simple ways, HR related ways to do that kind of thing, whether it be just making your forward-facing presence out there very veteran or more veteran focused, So it appeals so people can find you easily and make sure that you're a welcoming organization to veterans and some of their challenges. So whatever your niche is, you have to aggressively go out. But I will caution, a lot of organizations put up flashy things to attract veterans, and if there's no there, your reputation goes south very quickly. So you need to be sincere. You need to be aggressive in outreach to veterans and organizations. You can do that through traditional VSOs, or you can do it through other media outlets or media means. But consistency and sincerity and depth are the things that veterans are looking for. And if you don't have those, they're going to walk away from you. One other point I want to get back onto with technology is very interesting times before COVID with what I like to call the technology spiral. How we go from idea to fielding to obsolescence very quickly with regard to technology. And it used to be the fact that NASA and Department of Defense were the kind of generators of technology as it flew out. And that's changed. That's flipped on its head. In the civilian world, the technology spiral is much tighter. So idea to obsolescence is like that. And what we need to do to make sure that veterans transition well is we need to build a generation of agile learners. And because we're going to be jumping jobs and jumping communities and moving in and out of different healthcare systems and all that stuff, we have to have learners. We need a degree in learning. I think that's something that so folks can change midstream and adapt and not have all of these other hardships that are in the 8 dimensions of wellness. So I think that's something that started being addressed before COVID-19 and all this came up, but it's probably even more important now is build that foundation of the ability to learn and what is important there as we build these agile veterans and family members so they can adapt to the environment, because this stuff's going to be changing faster and faster and faster. We don't want people left behind. I can leave you with one last note. We don't need to build new programs necessarily across the country. We need to include veterans and those touched by military service in existing programs. That's where we get the biggest bang for the buck and the most depth in organizations.